No one wants to hear that they have to have heart surgery. But with modern technology and the experience that we've gained over the last several decades, we can perform these operations incredibly safely. I'm Dr. Roselli. I'm the chief of the section of adult cardiac surgery and the surgical director of the Aorta Center at the Cleveland Clinic. I've performed over 3,500 operations. The bulk of the work that I do involves the thoracic aorta, which is the main blood vessel in the chest, and the valves within the heart. Everything in cardiac surgery excited me when I was initially in my training. I've been really fortunate to be in the right place at the right time, but I was also given the opportunity to design my own specialty training in what we call hybrid aortic surgery, which means a combination of surgical and endovascular or catheter-based techniques. But I think we have to step back and think about the diseases that involve the aortic valve. And close to 2% of the population is born with what we call a bicuspid valve. There's a spectrum of what I call bicuspidness, where the valve malformed just a little bit in some folks and just a little bit more differently in other folks. And sometimes it doesn't become a serious problem that requires an operation ever. And sometimes it happens when you're 50, and sometimes when you're 20, and sometimes when you're an infant. The majority of bicuspid valves are not symptomatic at all, but they may be detected with, from a good physician who hears a murmur. What a murmur means is that there's a different sound. And you'll get a different sound if the blood is flowing a little differently across your valve. And so if you get some turbulent blood flow, a good physician can hear that. And so if we hear a murmur in a valve, then with modern imaging, the next thing to do is to get a look at it. And we can get a look at it with an ultrasound or an echocardiogram to see exactly what that valve looks like. Something that's unique to a patient with bicuspid aortic valve problem is that at least 40%, and maybe more than that, are prone to have what we call an aneurysm. And so an aneurysm means that that vessel's stretched out or dilated or enlarged. And it's important because even if your valve is working okay, you can have that vessel grow into an aneurysm that can put you at risk for having it rupture or dissect. Those are life-threatening things. When we find that someone has a bicuspid valve, whether it's symptomatic or not, it's important to remember that association with aneurysm needs to be studied, characterized in that patient, and a plan needs to be put in place about how that's going to be managed as well. When we make decisions about how to treat a particular problem in a patient, I think we have to think about tailoring that therapy to that patient's needs. There's a full spectrum of different options that we have today. From the surgical standpoint, when someone comes to us with an aneurysm of their aorta, with or without valve dysfunction, extends everything from an isolated valve replacement to a valve plus a partial aortic reconstruction to a complete reconstruction of the aorta with a repair and salvage of the valve. A David's procedure is technically an aortic root replacement with preservation of the aortic valve. Specifically, it's a valve-preserving root replacement with reimplantation of the valve. And the more experience that your team has with each of those various options, the better they can tailor that therapy to what your needs are as a patient. My advice to any patient who is given the diagnosis of an aortic aneurysm or valve disease for that matter is to learn what you can about it. Go to a center and find physicians who are willing to teach you about what's going on so you can make a shared decision about what's best for you.